Okay, we're recording.
Welcome to our AMCHIP conference session. The Black Mamas Matter Alliance has developed an issue brief on maternal mortality review committees from the perspective of community-based organizations. Through our presentation and discussion today, we aim to improve the effectiveness of MMRCs and better center the lived experiences of the women most impacted by maternal mortality and morbidity in the U.S. I am Brianna Lipscomb, Senior Manager of the Maternal Health and Rights Initiative at the Center for Reproductive Rights. I am also on the board of directors for the Black Mamas Matter Alliance, and I will be the moderator for this session today. Note that none of our speakers in this session have any relationships to disclose. And without further ado, I will introduce our first speaker. Angela Doyinsola-Aina is the Interim Executive Director of the Black Mamas Matter Alliance, where she works to convene Black maternal health professionals and community-based organizations to develop trainings, programs, quality improvement initiatives, research projects, and Black feminist advocacy strategies to advance holistic maternity service provision, policy, and systems change in global public health. She has over 14 years of public health experience, working in different capacities on projects focused on incorporating health equity strategies into reproductive and maternal health initiatives, strengthening strategic planning and community-based workforce development, and data collection. She holds a Master of Public Health degree in International and Women's Health from Morehouse School of Medicine and a Bachelor of Science degree from Georgia State University in Psychology and African American Studies. Angela's expertise and perspectives on Black maternal health have been featured in media outlets such as the Huffington Post, The Atlantic, The Root, and CNN. She is passionate about and committed to work that seeks to achieve the self-determination of women of African descent, the elimination of violence against women, the promotion of Black and African women's rights and leadership, and womanist solutions to social and economic injustices. Angela?
Thank you so much for the introduction, Brianna. Again, I am Angela Aina with the Black Mamas Matter Alliance. So a bit about BMMA. Next slide. The Black Mamas Matter Alliance is a national network of Black women-led birth and reproductive justice, community-based organizations, and multidisciplinary professionals working across the full spectrum of maternal and reproductive health. Our alliance includes a diverse range of professionals from midwives and doulas to OBGYNs, nurses, lawyers, academics, artists, and of course, public health researchers. BMMA's niche is to centering Black women's activism, leadership, scholarship, and maternal care and birthing work. Of course, below you can see an image, a beautiful image of all the logos of the organizations that are part of the Alliance and of all of the beautiful smiling faces of the individuals that make up our membership. Next slide. Our mission is to center Black mamas to advocate, drive research, build power, and shift culture for Black maternal health rights and justice, so that they have the rights, respect, and resources to thrive before, during, and after pregnancy. And of course, on your screens, you can see our 4 bucket areas, which are to change policy by introducing and advancing policy grounded in the human rights framework, cultivate research, ensuring that we're really centering the scholarship and knowledge base from community-oriented solutions in maternity care, and also advancing care for Black mamas, ensuring that that care is holistic and comprehensive and really incorporates the full spectrum of maternal and reproductive health care across the lifespan. And shifting culture, we know that is so important to shift the narrative and change the narrative around Black motherhood and how we present and do this work. Next slide. We think of maternal mortality through a global lens, having a particular burden on Black women in the US and sub-Saharan Africa. So therefore, our definition of Black mamas is inclusive of the full diversity of Blackness, ensuring that it is inclusive of Afro-Latinas, African Americans, Afro-Caribbean, Black and African immigrants, and the lived experiences of all birthing persons, to include gender nonconforming and trans folks when we're talking about Black mamas. We recognize, celebrate, and support those who care for and mother our families and communities, whether they have given birth or not. We stand in solidarity with all Black mamas. Next slide. So we know that we are facing a maternal health crisis in the United States. While we've seen the maternal mortality rate decline in many countries around the world in the last 30 years, during this same time period, the United States maternal mortality rate rose significantly from 12 per 100,000 live deaths in 1990 to 28 per 100 live 28 per 100 live births in 2013. Even more disturbingly, the maternal mortality rate for Black women is 3 to 5 times greater than that of white women at a rate of 40.4 per 100,000 live births. Ironically, the US spends about $111 billion annually on maternal and newborn care, which indicates that we need to do things differently as it relates to public health and medicine. The most important thing, though, to note is that these deaths are preventable. The Center for Disease Control and Prevention has also recently indicated and acknowledged the role of racism and the need to address significant differences in racial and ethnic disparities in pregnancy-related mortality. Next slide. It is important, and it's part of our core values, to always say her name. We have to say the names of those we've lost to maternal mortality and show the faces of the Black women that were victims to systemic racist medical practices that contributed to their demise. Erica Garner, Dr. Shalon Irving, Kira Dixon Johnson, Crystal Galloway, Amber Rose Isaacs, LaShonda Hazard, and unfortunately, more recently, Sha'Asia Washington, were all Black women from different economic and educational backgrounds who all died because they were neglected, disrespected, and denied timely quality care before, during, and after pregnancy. Next slide. Next slide. In public health, we are used to operating our programs, establishing evidence-based practices and health policy through the use of indicators and performance measures. However, when we are talking about racial disparities, relying solely on indicators and performance methods often causes us to leave out a missing part of the experience, especially of being a Black woman in this country. And this is why, for Black Mamas Matter Alliance, it is important to frame how we do this work in Black maternal health. Our work is centered and built on reproductive justice, birth justice, and human rights frameworks. Reproductive justice, which was coined by Black women in 1994 and ushered in as a form of practice and a movement by the SisterSong Women of Color Reproductive Justice Collective, is described as the human right to maintain personal bodily autonomy. It's the right to not have children and to have access to the resources needed to carry out one's own reproductive decisions. And it's the right to have children and to parent children that you already have in safe and violence-free, healthy environments. Next slide. Also, our framework around birth justice, as defined by Black women birthing justice, aims to dismantle inequalities of race, class, gender, and sexuality that lead to negative birth experiences. Birth justice exists when women and trans folks are empowered during pregnancy, labor, childbirth, and postpartum to make healthy decisions for themselves, their babies, and families. Next slide. This slide simply shows examples of recent instances of reproductive and birth injustices reported in the news and demonstrates why we need to keep fighting for reproductive justice. It is important to note that unlike reproductive justice, birth justice focuses specifically on human rights during the perinatal and postpartum period. So even as you see on the slide, some examples of some of the reproductive injustices is the significant burden that is placed on Black mothers, most especially around police brutality and the heightened stress around the well-being of their children. Also, the COVID-19 related policies that are pushing abortion bans are also a form of reproductive injustice. And then in terms of reproductive injustices, as you can see on your screen, some headlines around folks who are incarcerated being denied proper care during labor and delivery. And then of course, news that have come out around separation of newborns in hospitals, during this COVID-19 pandemic from their mothers and not being able to do the skin to skin immediately after birth. Also, we want to showcase that this slide shows a birth justice bill of rights developed by two of our kindred partners, which is the Southern Birth Network and the National Black Midwives Alliance. And more of that information can be found on their website. Next slide. So why a community stakeholder response to maternal mortality review committees? Several of the members of the Black Mamas Matter Alliance serve on their respective maternal mortality review committees, whether at the city level or at the state level, and have experienced differing experiences, both positive and negative, being a part of these maternal mortality review committees. They have seen hierarchies in decision-making that has not necessarily lended a positive outcome in terms of recommendations as a result of reviewing case deaths. Also experiences of reinforcement of power dynamics. And then of course, what is also has been interesting is that several of folks that serve on the MMRCs that are coming from a community perspective have also lifted up experiencing secondary trauma, just even in the process of reviewing these maternal deaths and how each case is talked about, and really not having a mechanism to address this harm as part of the review process. And so therefore we did come together last year to think about how we can really have a call to action and provide some guidance as a way to reevaluate and think differently about the processes and goals of the maternal mortality review committees so that it can improve their recommendation outcomes, especially in wanting to not only eliminate maternal deaths, but advance and improve maternal health equity. I'll now pass it over to Brianna.
Angela, thank you for providing that framing and context for this discussion. It's just really a good reminder of why we do this work, why we approach it from a reproductive justice, birth justice, and human rights perspective. So now I want to shift us a little bit to briefly provide information about MMRCs more generally, and then Dr. Parrott will walk us through the recommendations set forth by BMMA. So you've already heard from Angela a quick review of the state of maternal mortality in the US. Our rates continue to be the highest among wealthy developed countries. Black women continue to be disproportionately impacted by both maternal mortality and morbidity. And data show that a large percentage of pregnancy-related maternal deaths in the US are preventable. Yet while we're faced with these harrowing statistics, we are also grappling with a lack of sufficient data collected on maternal deaths. So unlike countries that have a national healthcare system that can help standardize and streamline healthcare data, information about maternal health in the US is spread across a wider range of stakeholders. So the US healthcare system is a complex mix of both public and private providers, payers, and facilities that all provide a varied level of services. And then of course, they all have their data sets of their own. So this is partially the reason that MMRCs are so valuable, but it wasn't until recent years that many states decided to formally establish their state maternal mortality review committee. I think it's also important to remember that there have been some real barriers to states collecting data in a systematic manner. And one example of that is the death certificate. So death certificates that are used to identify maternal deaths for a long time were not the same across all states. So there's a current, on the current form of the death certificate, there is a pregnancy checkbox. But because states adopted the pregnancy checkbox question at different points throughout the last decade, comparing and combining data from different states' death certificates during that time period is complicated. So before MMRCs, there was a lack of systematic processes for data collection on maternal deaths. And to a certain extent, this still exists. So there's still, to a certain extent, a lack of systematic processes. But you'll hear more about this from Dr. Parrott later in the session. So there are also other concerns about underreporting of pregnancy-related deaths, injuries, and morbidity. And once again, before MMRCs, we were really limited on the type of data and the type of information available related to the circumstances of a maternal death. So what is the role of maternal mortality review committees? Well, MMRCs are one mechanism to investigate the circumstances of a maternal death, to acknowledge the contributing factors, and to make recommendations to prevent those deaths. These committees are a jurisdictional body tasked with performing comprehensive reviews of maternal deaths within a year after birth of pregnancy. And it's important to note that some states review both pregnancy-related and pregnancy-associated deaths, while others limit reviews only to pregnancy-related deaths. I also want to clarify that we often refer to state MMRCs, but there are some city-level reviews, like in New York City, as well as in Washington, D.C. So as you can see, it's on the graphic at the bottom of your screen. Once a maternal death occurs and the case is identified, cases are abstracted, the committee reviews the case, they make recommendations, and they identify actionable items. So critical components of the case review process include assessing and identifying contributing factors, determining the preventability of the death, and examining root causes. So it's evident that MMRCs are a critical source of quality maternal mortality data in the US. And I want to briefly acknowledge the legislative and administrative mechanisms that support the operations of MMRCs. So the CDC has been providing ongoing technical assistance, guidance, and support to MMRCs for a while. But it wasn't until 2018 that Congress passed the Preventing Maternal Deaths Act, which allocated funds to better support state MMRC operations. And so it authorized the CDC to really ramp up that support. So this is a major accomplishment at the federal level, and the bill authorized a $58 million allocation in funding through 2023. So that's major. Additionally, the U.S. Department of Health and Human Services, through HRSA funding for the Alliance for Innovation on Maternal Health, or as we know it as the AIM program, provides support and guidance to MMRCs and perinatal quality collaboratives. And this support is particularly useful for the quality improvement related recommendations developed by MMRCs. Finally, I just want to note that many jurisdictions have passed authorizing legislation to establish their committees. So while this is not required, many states find that having a law helps support long-term engagement of the committee. And there are pros and cons to this approach. Nevertheless, currently there are 41 states and 2 cities that have active MMRCs. And across the US, at least 46 states hold some level of maternal death review, even if they're not necessarily engaged with the CDC's process. So this is a graphic that depicts the saturation of MMRCs across the US. You'll see that all states now either have an MMRC or they are currently in the planning process. And this map looked very different just 3 years ago. So we are making progress, but there are clear areas for improvement. So now I want to turn it over to Dr. Jamila Parrott, who will discuss the challenges that MMRCs continue to face and community-driven best practices to improving the effectiveness of the committees. But first, let me give her a proper introduction. So Dr. Jamila Parrott is a fellowship-trained, board-certified obstetrician and gynecologist with a comprehensive background in family planning and reproductive health. Dr. Parrott provides on-the-ground community-based care, focusing primarily on the intersection of sexual health, reproductive rights, and social justice. In addition to her work as a clinical provider in Washington, D.C., Maryland, and Virginia, she serves as a reproductive healthcare consultant where she develops, organizes, and facilitates health education workshops and outreach events to diverse communities and community partners. Dr. Parrott is a graduate of Howard University College of Medicine and completed her residency training in obstetrics and gynecology at Pennsylvania Hospital in Philadelphia. She completed a family planning fellowship at the Johns Hopkins University in Baltimore, Maryland. During her fellowship training, Dr. Parrott received a master's degree in public health from Johns Hopkins Bloomberg School of Public Health. After completion of her fellowship, she served as the medical director at Planned Parenthood of Metropolitan Washington, D.C. Incorporated until 2016. She is a member of the Black Mamas Matter Alliance and serves via mayoral appointment to Washington, D.C.'s Maternal Mortality Review Committee. She also serves as chair of ACOG's Committee for the Healthcare for Underserved Women. Dr. Parrott?
Thank you so much, Brianna, and thank you to Angela. You've all heard quite a bit by now, and I hope it conveys not just the importance of having an MMRC, but about the role it can play in impacting health outcomes. So at this point, as was mentioned, I want to shift and talk a bit about the challenges that are faced by MMRCs as they try to operationalize their intentions to do good work with the realities of what it actually means to engage in a review process. Some of the MMRCs, as you've heard, are newly established and supported with the recent funding efforts, and others have been in existence for years. But whether they're newly formed or already established, many of the challenges are the same. And these challenges include difficulties with standardization of process, for example, for tracking and counting maternal deaths, both at the national and the state level. Access to consistent, high quality, and reliable data that identify both the characteristics of those who die during pregnancy due to pregnancy complications and the specific circumstances that lead to these deaths is really essential to inform critical action steps and also for developing strategies to prevent maternal mortality and severe maternal morbidity. And although we've heard some about funding for these state MMRCs, that funding is not consistent or even uniform across the country. And as a result, some states who are interested in starting, supporting, or even sustaining their own review committees are struggling to figure out how to pay for them. The result is a reliance often on state legislation, and in many cases, even the infrastructure of state organizations, not just for funding, but also to outline process and procedure, including the composition of the committee, reporting expectations and timelines for work. This in many cases presents a real ethical concern in terms of assessing accountability of these review committees and implementation of active steps for change. And finally, there's the risk of falling back into traditional and historical methods of assigning causality to maternal deaths. And often these determinations lean in to familiar tropes that blame poor outcomes on lack of personal responsibility, as opposed to examining systems level issues that contribute to deaths. Next slide. With this in mind, we at the Black Mamas Matter Alliance understand that to evaluate the nature and true magnitude of the maternal health crisis occurring, states need systems to collect accurate and complete data on a range of variables. Maternal mortality review committees are one piece of this system, but we also recognize that the recommendation from these committees are shaped greatly by the data they collect, the composition of the committee, and the values they hold around transparency and accountability. In truth, maternal health surveillance activities should be a core and routine component of the public health work in which state departments engage, and a standardized maternal mortality review process can integrate these data collection and case identification activities into its operations. Next slide. As I briefly alluded to above, data quality and availability has been a significant challenge for many committees. The seemingly simple starting point of determining what we mean by maternal mortality and how we count it at the outset is critical to identifying opportunities to intervene and prevent future harm. One clear example is in understanding the difference between pregnancy-related deaths and pregnancy-associated deaths, and then deciding how to include these data in our counts. A pregnancy-related death is the death of a person during their pregnancy or within 1 year of the end of their pregnancy from a pregnancy complication, a chain of events initiated by that pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Alternatively, pregnancy-associated deaths are the deaths of a person during their pregnancy or within 1 year of the end of a pregnancy from a cause that is not related to pregnancy. We at BMMA advocate for MMRCs to collect data concerning pregnancy-related deaths that goes beyond the cause of death in order to evaluate quality of care and maternity services. And so this means giving equal priority to an examination of pregnancy-associated deaths as well as pregnancy-related deaths. This, of course, is not simple because it requires that we advocate for improved and standardized surveillance systems that can capture these data points. And we have to be all speaking the same language in order to analyze the data as we work to affect change. And then once we have this data, how do we operationalize the need to triangulate data on pregnancy-related deaths with data on severe maternal morbidity and near misses? This is critical because it will give us a broader understanding of systemic quality of care issues that impact Black birthing people and contribute to mortality risk. And finally, an equal amount of attention, funding, and thought should be given to how we translate maternal health review data and findings into publicly accessible reports, how we use these data to create evidence-informed laws and policies when seeking solutions around both systemic issues and those related to individual patient outcomes is vital. Next slide. If we understand that decisions and recommendations coming out of MMRCs are strongly informed by the data received and the analysis of that data, then we have to also understand how important the composition of MMRCs are for understanding all of the ways systems, structures, and social determinants of health shape maternal mortality risk. And this begins by taking an honest look at who's sitting around the table. Traditionally, MMRCs have been staffed by physicians and medical providers. And although we as providers give an important piece of the story, we need a broader frame. If our goal is for these multidisciplinary committees in states and cities to serve to perform comprehensive reviews of death among pregnant and recently postpartum people, then we must cast a wider net. And this means including our colleagues across disciplines like public health and mental health and behavioral health, but also the inclusion of patient advocacy groups and community-based organizations. The committee charge is to evaluate and to understand the factors that contributed to the death of this person. And often this is much more than what happens at the time of the interface with the formal healthcare system during delivery or in the postpartum period. Because maternal deaths among Black women and birthing people often result from a complex combination of systemic barriers and implicit bias, MMRCs must have the capacity to identify and assess the impact of these social determinants as well. And though the literature supports the underlying role that social determinants play, MMRCs rarely identify community factors as contributing to pregnancy-related death. And in addition, we have to make an intentional effort to ensure that the racial and ethnic composition of the committee reflects the racial and ethnic diversity of those most impacted by maternal mortality in the member composition of the MMRC. It's not enough to simply invite diverse participation though. Mechanisms have to be put in place to ensure that meaningful engagement is possible. And that can include things like providing practical support, for example, for community members to attend meetings, support for transportation, childcare, meals as needed. But it also means being thoughtful about the time and location where meetings are being held. Who is able to attend a meeting of the MMRC at 10 o'clock on a Thursday, for example? Does this mean that participation in the MMRC requires that you take off from work, assuming the individual even has a job or works in a field that allows them to do so? Is the location accessible and convenient to access? The bottom line is that if we want diverse perspectives, we must equitably support diverse engagement. Next slide. A key part of both the formation, practice, and outcomes of MMRC development is how these activities are communicated with the public and policymakers. This is crucial, especially given the overarching goal of MMRCs to develop solutions and recommendations to prevent future deaths and morbidity. In order to do that, we must provide civil society members with information about state efforts to prevent maternal morbidity and mortality and the ways these efforts are working to ensure safe and respectful maternal health care. It is useful in these cases to share best practices and lessons learned across organizations like MMRCs, but also across state public health departments, community organizations, and other medical entities. And of course, we want to ensure that the solutions and recommendations developed are grounded in health equity and engaged participation and knowledge of effective communities, especially centering those solutions that emphasize asset-based, resilience, cultural models of care. These are proven ways to move from the traditional shame and blame narratives that have historically come out of MMRCs in their recommendations. Next slide. And finally, we need to start thinking about ways to hold healthcare systems and providers accountable for providing culturally responsive, respectful maternal care. But accountability here doesn't just apply to the outcomes at a hospital level, but also thinking about how MMRC members are accountable to one another on the committee and the community that we're serving. And this means moving away from those practices that reinforce hierarchical decision-making and traditional power dynamics and structures. Next slide. Maternal mortality review committees are uniquely positioned to do much of the work we need in addressing inequities in maternal health, mortality, and severe maternal morbidity. Reframing and rethinking MMRCs is critical to achieving this goal. Next slide. Whether you're in a state with a newly formed or a well-established MMRC, there's an opportunity here to interrupt and exchange traditional practices in these spaces for those that center care grounded in justice and equity frameworks. And if you're in a state where formal review processes have not yet been implemented, there's still an opportunity there for state health departments to work to strengthen data collection strategies in order to identify the scope and nature of pregnancy-related deaths, pregnancy-associated deaths, and severe maternal morbidity. MMRCs and state health departments should share the best practices learned during the review process and via subsequent intervention programs with other states to improve review mechanisms and establish innovative interventions. Keeping in mind that the numbers only tell a small part of the story. Involving impacted communities is necessary to support the data collection, but also to ensure that the policies developed from MMRCs are informed deeply by those who are most affected. Next slide. I'll take this opportunity to turn this back over to Brianna.
Thank you, Dr. Parrott, and thank you, Angela, for your presentations. In the remaining time that we have, I do have a few questions for you all. And Dr. Parrott, this probably, I think, dovetails nicely off of your presentation. So earlier this year, CDC announced that they have added 3 new contributing factors to the Maria Committee Decisions Form. And for those that aren't aware, the Maria system is basically a database where maternal mortality review committees are able to input data that they've gathered around maternal deaths. And so this Maria system, they have a committee form that the committees actually use to make decisions regarding the circumstances of that maternal death. So on that form, they've added 3 new factors, being discrimination, interpersonal racism, and structural racism. And these new contributing factors are aimed at capturing the influence of racism and bias on maternal deaths. So this question is for both you, Dr. Parrott, Angela, feel free to weigh in as well. But what are the opportunities or barriers that you foresee MMRCs facing in using these new contributing factors? And then how does the composition of the committee membership impact the utility of this recent change to the form?
That's a wonderful question, and I'm so glad to have an opportunity to talk about it, because the addition of racism into the Maria form, this form that we're using in a standardized way to evaluate for contributing factors and causes of maternal mortality, is a really important shift in the way we're thinking about maternal morbidity and mortality in this country. The reality is that even when you control for economics, education, healthcare systems, we still see that these inequities and outcomes for Black women specifically remain. And so what that means is that we have to move away from assigning a purely biological cause for these health inequities. And so at BMMA and with a lot of other organizations, we're hearing more and more commonly the phrase, it's racism, not race, that's causing the deaths of Black women. and Indigenous women at highest proportions. And so what that means is that just like the way we think about our systems and structures in hospitals and at an individual level and in communities as contributing factors, we have to begin by acknowledging the history of racism in medicine and how that influences decision-making around medical care, how structural racism inside the hospital system, outside the hospital system, and in our community contribute to these deaths as well. And so by way of example, if you're thinking about what that actually looks like in terms of assessing structural racism as a contributing factor, then we can look at the status of health in the community that the individual is coming from, for example. We know that structural racism plays a role in your ability to be able to get access to care, quality care in your own community, your ability to be able to access healthy food, to be able to drink clean water in your own community. Structural racism contributes to environmental factors that impact our health outcomes. Structural racism also contributes to the reasons why hospitals and health centers and clinics in certain communities are under-resourced and understaffed. So beginning from that point, acknowledging that racism is embedded in all of these systems and that has a way of shaping health outcomes as well. The last thing that I'll say about that is to circle back to a point that Angela made early on when we saw the list of those Black women who have died. One key factor that is continuing to raise itself is the way that Black women are not listened to when we seek medical care. And that is a cause that is caused by racism in our healthcare system. And we have to be able to name that, to be able to talk clearly and speak about ways to begin to address it. That doesn't mean that this is not without its challenges in operationalizing these ideas in our MMRCs, but it certainly is a starting point. And I welcome any additions from Angela as well.
Absolutely. Dr. Parrott, thank you so much for that explanation. And I definitely echo everything that Dr. Parrott just mentioned in response to the question. The other thing that I wanted to uplift in terms of the second part of your question, Brianna, is in terms of operationalizing, as Dr. Parrott mentioned, some of these three new contributing factors that the CDC added to the Maria decision form is really the importance. This further elevates the importance of diversifying the composition of the committee membership in and of itself. And so even when we talk about community perspectives on the whole process around the Maternal Mortality Review Committee, we're talking about ensuring that those community perspectives are inclusive of local and culturally congruent healthcare providers. So, like physicians like Dr. Parrott, who works locally and serves her community. Also thinking of community-based midwives and doulas and other social workers, lactation consultants, other perinatal health workers to be a part of, the composition of the MMRCs, because again, having those diverse perspectives to also contribute to how these cases are reviewed helps to further expand even the recommendations that come out of the MMRCs. And our hope is that, again, by CDC adding these three new contributing factors, that it will enrich and expand the recommendations that come out of MMRCs so that states can begin to make those necessary changes in their public health and medical and healthcare systems.
Thank you, Angela and Dr. Parrott.
If I could just add one
Sure.
other thing to that, and that's really around that composition, because it's such an important point when we're thinking about who's sitting around the table. And I love that Angela mentioned the importance of community-based organizations and community-facing providers, because that is key. And what we want to make sure is that these folks are included and their voices are included at an equal and an equitable level when it comes to the decision making around the preventable nature of these deaths. What we're seeing across the country is sometimes there are MMRCs that are including community members for pieces or portions of the conversation, and then they, for example, may not have a vote in when it comes time to make decisions around whether or not this death was preventable, and to be included in recommendations for projects and interventions moving forward. So understanding including community members in this process does not just simply mean you allow them to attend the meeting. It means ensuring that their voices are held equitably in that space, and that their contributions are held at the same level as traditional members when we think about MMRCs like physicians.
Thank you, Dr. Parrott. So in our last few minutes that we have, we can't have a presentation in this day and age without mentioning COVID-19. And Angela, in fact, in your presentation, you kind of outlined just a few of the birth and reproductive injustices that are occurring during the COVID-19 pandemic. As you indicated, we've already seen reports of maternal deaths that have occurred recently, like Amber Isaac, Shasia Washington, Nicole Thea, all of which were devastating outcomes, which raised alarm about racism and neglect in our healthcare system. And so recognizing that COVID-19 has further burdened an already strained healthcare system, I'm curious from both of you, what role do you all see that MMRCs have in assuring that maternal health harms are not exacerbated by the pandemic? And then also, what role do MMRCs have in measuring the harms that are occurring?
Yeah, thank you so much for that question, Brianna. I will kind of try my best to think about what roles MMRCs have, and definitely look to Dr. Parrott to speak more so to the specifics, but thinking more broadly about COVID-19 and the unfortunate public health response, and the fact that, again, unfortunately, the pandemic just really exposed the fact that we really have undervalued and haven't even done the necessary steps to properly invest and build out our public health infrastructure, especially around emergency preparedness. And even during this pandemic, because of the varying decision-making process, varying information, it has had a trickle-down effect even into our healthcare systems. And so that has even showed up in how different hospital systems have implemented varied policies. So as I mentioned before, during this pandemic, we have heard from folks who provide services, perinatal services to their clients, that either if their pregnancy is not necessarily considered high risk, there are some instances where people have been turned away and asked to, give birth in a different location. People have experienced other hospital policies whereby they're restricted in bringing any kind of support person with them. You know, we know that there have been a number of doulas who have not been able to support their clients at the hospital during the labor and delivery process. And then again, as I mentioned before, there have been stories that have been showing up in the news, but we know that it's, of course, more vast than what the news is showcasing of, you know, most especially Black and Brown and Native and Indigenous women having very discriminatory and experiencing actual mistreatment and neglect and disrespect during the childbirth process, during this pandemic at hospital systems. And, you know, and we know the unfortunate stories of Sha'Asia Washington and Amber Isaacs as a result of, you know, those neglects. And so definitely, I do think that, again, the MMRCs will eventually receive some of these cases, right? Once they figure out, well, once they figure out how they're going to convene in this age of COVID-19 and physical distancing. And really need, as a result of reviewing these deaths, really need to take a further and deeper dive look at how we provide care in the healthcare system even more, and thinking about it from a systemic way. And again, as I mentioned before, MMRCs can utilize the power that they do have to inform policy change in the recommendations that they make. And most importantly, it is important that even in that review process, that they expand how they look at these cases, to look at it from a systemic perspective, and thinking about diverse and holistic forms of prevention so that we don't have these situations. I'll turn it over to Dr. Parrott, who could probably speak a little bit more to what MMRCs can be doing, especially in light of this pandemic.
So I thank you so much, Angela. And actually, you said it perfectly, and I don't have a ton more to add. I think the reality is that that COVID-19 did not create these inequities, but it certainly has exacerbated them, much of in the way that Angela mentioned. I know that for myself as a physician, as a mother and a Black woman, I've seen how COVID has ravaged many of our communities, and these inequities on top of inequities have really made the circumstances for many of us more challenging than ever. As somebody who sits on an MMRC and who does lots of work around the role of MMRCs, I would agree with Angela's statement as well that, you know, it's only a matter of time before these cases make their way to the MMRC as well. The question becomes, though, what will the MMRCs do with this data when it gets across our desks, right? And so the reality is, as we're thinking about our specific positionality on MMRCs and what our roles are, then we have to be very clear about making recommendations to eliminate these inequities or to move toward equitable care, keeping in mind those who are most likely to be impacted by the policies and interventions we put in place. To Angela's point, the policies that have been implemented around physical distancing for COVID, things like limiting support people in labor and delivery, about restricting options for where folks can birth, are known factors that disproportionately impact communities that are already experiencing inequities around maternal mortality. So it's very critical when we put these policies in place, we think intentionally about who's more likely to be impacted and what we can do to mitigate those risks. And I think that the MMRC's role here is that one, for sure.
Thank you, Dr. Parrott, and thank you, Angela. We are getting close to time, so I just want to do some quick wrap up. So first, specifically related to COVID-19, I just want to alert people that on the blackmamasmatter.org website, under the resources tab, there is actually a webinar that is available for viewing on Black maternal health and the US COVID-19 response. Also on the reproductiverights.org website, the Center for Reproductive Rights has done an issue brief on safeguarding maternal health and rights in the US during the COVID-19 pandemic. So those are a few resources for you. I also encourage you all to follow Black Mamas Matter on their social media platforms, as well as Dr. Jamila Parrott. The issue brief that the Alliance has pulled together specifically on kind of a community-based perspective on MMRCs will be posted on Black Mamas Matter Alliance's website soon. So make sure you go to the website and sign up for updates so that you can be made aware of when that is posted on the website. If there's nothing else from Dr. Parrott or Angela, I just want to thank you all so much for your presentations today and this robust discussion that we were able to have even virtually. And I want to thank everyone for attending the session, for your time and your attention. And this concludes our session. Thank you.
Thank you so much.
Thank you.